Bonjour à toutes et à tous et bienvenue sur Kinédi. Aujourd'hui, j'ai le plaisir de vous présenter un autre épisode en version anglaise avec une experte de l'épaule, le docteur Angela Cadogan. Angela va nous décrire son parcours, sa méthode de travail, avec toutes les étapes dans le parcours du patient qu'elle accueille dans sa clinique spécialisée en douleurs d'épaule en Nouvelle-Zélande. Angela va d'abord nous parler de la notion de triage et comment écarter les drapeaux rouges pour une douleur d'épaule. Puis elle va nous décrire tous les questionnaires qu'elle envoie à chaque patient avant leur première consultation. Ensuite, elle va nous parler des types de pathologies d'épaule, à savoir l'épaule instable, l'épaule raide, la douleur acromioclaviculaire et la rupture de coiffe des rotateurs. Elle va nous décrire les tests cliniques qu'elle utilise, ceux qu'elle utilise le moins et pourquoi, et ensuite nous expliquer pour chaque pathologie les types d'exercices recommandés. Enfin, nous allons parler de l'aspect biopsychosocial et de son importance dans la douleur d'épaule, ainsi que de la kinésiophobie chez certains patients aux douleurs spécifiques. Cet épisode est une mine d'informations avec une experte en la matière, car en plus d'être très claire et concise, Angela nous propose un tableau clinique à la fois riche et très complet sur les pathologies de l'épaule. Cet épisode est en version originale, mais comme pour le podcast avec Marc Laslett, la version entièrement traduite en français sera publiée la semaine prochaine. Enfin, si vous voulez en savoir plus sur l'épaule, je vous invite à regarder les liens dans la description de l'épisode avec des e-books gratuits qu'Angela a mis à notre disposition, mais aussi avec toutes ses formations. Hello, Angela. Thank you so much for joining me today.
Thank you, Gabrielle. It's very much my pleasure to be here.
Well, likewise, I'm very excited about this podcast. We're going to talk about shoulder. This is your theme of expertise because you actually are a shoulder specialist in New Zealand, correct?
That's right. Yes, I'm a registered physiotherapy specialist in New Zealand, and the shoulder is my area of subspecialty.
Yeah. Are there many shoulder specialists in New Zealand, or are you the only one?
There's a total of 18 physiotherapy specialists in New Zealand now, but for shoulder subspecialty, there's only 2. So myself and Dr. Margie Olds. And yeah, Margie works up in Auckland in New Zealand, and I'm based in Christchurch in the South Island of New Zealand.
Lovely. And can you tell us a little bit about yourself and why you decided to become a shoulder specialist?
Yes, well, that was quite a long journey. I guess the short story, I graduated as a new graduate. I actually worked in a cardiorespiratory hospital as my first job. And as many physios do from New Zealand, after 2 years went overseas. So I worked in America for 2 years and did a mixture of things in America. Came back to New Zealand, and that's when I started working in private practice. So that's mostly musculoskeletal, injury-related and trauma-related musculoskeletal physiotherapy. And I'd always had an interest in that musculoskeletal and even the sports physiotherapy area. And I actually initially went more down a sports physiotherapy path. So I began to travel with sports teams. I went to Australia. I did my master's degree in sports physiotherapy. And when I came back from Australia, I got a job working with the New Zealand women's cricket team. And I'm sure many of you are familiar with cricket, but they do get a lot of throwing injuries. And that's really where my shoulder interest started. So I became very interested in the throwing shoulder, went a lot more down that path for several years. That was originally the intention for my PhD, actually, was a PhD in the throwing shoulder. But in doing the background work that you have to do for a PhD, it became clear that there were much bigger issues, and particularly around diagnosis. So if we're looking at investigating a particular shoulder condition, the first question was, well, how good are we actually at being able to identify that condition and actually make that diagnosis? So that led me down more of a diagnostic pathway, and then I met Dr. Mark Laslett, who I know you've had on your podcast before, and ended up doing my PhD in the diagnosis of shoulder pain. And Mark was one of my supervisors for that. And since then, so I finished my PhD in 2012, and since then I've only seen shoulders. So that is now all I see in my clinical practice.
Okay. Do you work with other people in a team in your clinical
I work,
practice?
yes, so I work for myself. I work as a consultant, and I don't have any staff who work for me specifically, but I do work within a multidisciplinary practice. So we do have doctors available, sports medicine doctors, we have other allied health practitioners who work within that environment. So I'm in a multidisciplinary environment, but I just consult with my own patients.
Okay. So what does your daily job look like or weekly on a weekly basis potentially? Because I know you do also online training. So how do you organize yourself?
That's a very good question, and sometimes I don't. um, oh, excuse me, I'm just getting over a cold. My week is varied. I do, in addition to my consulting role in private practice, I do also have two other roles. So I work in the local hospital in the orthopedic department, doing an orthopedic triage role. That is one day every fortnight, every 2 weeks. So it's not a big part of what I do, but I've been doing that for 10 years. And the combination is actually nice because the work I do in private practice is mostly, although by the time patients see me, they've often had a problem for a long time, so
Mhm.
minimum 1 to 2 years, sometimes up to 10 to 15 years. So, but it tends to be more sequelae of injury or trauma related problems. But in the hospital, it's the other end of the spectrum. So it's very much the non traumatic chronic conditions. So I'm very lucky that I get to see the range of conditions from acute injury right through to the non acute and chronic shoulder problems. So the orthopedic role, then I also do education. So I do online courses for physiotherapists, and also I teach some practical courses for physiotherapists as well. So my week varies depending on what my schedule is. I generally do 3 days a week in the clinic most weeks. I do 1 day per fortnight in the hospital, and my teaching is in the other time, the spare time. And there's different times. There's different amounts of hours are allocated for each. But yeah, it is a nice variety.
Mhm. Can we talk about the notion of triage? What do you mean by that?
Okay, so triage really, the word really means prioritizing patients, and it depends on the context and what you mean by that term. When I say orthopedic triage, so in the orthopedic service, we are triaging GP, so general practitioner referrals, who are referring patients to the orthopedic service either because they don't have a diagnosis, they're not sure what the problem is, or there is a diagnosis and the question is, does this patient need surgery? So one of my roles there is to go through the referrals, the paper referrals that come in from the general practitioners, and triage or prioritize those according to, is it clearly a surgical problem, in which case it goes in the surgery pile to see the surgeon, or do we not have enough diagnostic information? If the diagnosis is unclear, or if they have a condition that needs a trial of non-surgical management before seeing the surgeon, then that's my job to allocate to the non-surgical service. So the triage, when I say triage, refers to the paper referrals and allocating them either to a surgical or non-surgical pathway. Then if it's allocated to the non-surgical pathway, my job then is to do the clinic assessment for the patient and make a differential diagnosis, order any investigations if they need imaging or other tests, follow those up, get the diagnosis, get them on a treatment pathway appropriate for their condition. And then if it ends up that they exhaust all of their non-surgical treatments and they still are having problems, then we can refer them through to be assessed by the surgeon. So it's primarily really to take the burden off, because I'm sure, as everywhere else in the world, the orthopedic services have a lot of referrals for patients very often who may not need surgery. So it's just a way of using physiotherapists to help relieve that burden.
Yeah. Mhm. So can we talk a little bit about your assessment process? And how do you treat a new patient that comes to you after having taken off all the red flags, all the traumatic, let's say fractures or sports trauma, etc.? What's the process?
Okay, so in my role as a specialist, in order to see me, the patients are referred with the criteria that they have either already had a course of physiotherapy and they are not progressing and they're asking for a rehabilitation review, or they are considered to be complex. So those are the only patients I see now. So I'm not seeing the acute patients. So my assessment is a bit different probably from what you would do if you were just seeing the patient for the very first time. So in my setting, and most of the other specialists in New Zealand, the physiotherapy specialists work in a very similar way, is the first thing that I do before I even see the patient is that they have already completed some online questionnaires for me. The online questionnaires cover a range of things. They collect all the demographic information about the patient, brief information about their social situation, their recreation, their sports, etc. We get health information, so medical conditions, surgical history, medications. I also collect pain and disability information. So I collect pain scores, visual analog scores for pain out of 10. They complete a SPADI, shoulder pain and disability index score. If they have instability in the shoulder, they'll complete the Oxford Instability Score. And then there are a range. I collect 3 other screening questionnaires. One is for kinesiophobia, so fear of movement, TSK score, the PHQ-2, which is a screening tool for depression and anxiety, for identifying patients who may have indicators of a depressive disorder. And there is one other, it's just escaped me now. It'll come back. But yeah, so just a brief set of screening tools. So I can get a bit of an idea of the patient, what's important to them, what activities they're involved in, their health history, and just a very brief psychosocial screen. There's a lot more to that psychosocial screening, but the questionnaires that I collect really are the ones in my experience that give you good information that there may be a concern about kinesiophobia. Pain self-efficacy was the other one that I just forgot earlier, and whether there's any significant depressive disorders. So that all goes on before I even see the patient, and then that's automated. I get a report which is attached to their referral before the patient comes in. So once the patient comes in, I do my typical clinical assessment. And one thing I've learned in the specialist setting is to assume nothing. So
Yeah.
just because somebody is referred with a rotator cuff pain or, frozen shoulder, I don't ever assume that is the case. So in all cases, I always start right back at the very beginning with a very basic shoulder assessment, just to make sure that nothing has been missed from a diagnosis point of view. And in a surprising number of cases, that actually is the case, is that you will pick up something that possibly has evolved since the referral was made. Sometimes patients have to wait a month or 2 to see me, sometimes a little bit longer, depending on referrals. But it's just things like frozen shoulder, for example, that can evolve over a period of time. And from the time the patient is referred and maybe 2 months later, the clinical picture can look sometimes different. So I always assume nothing, do my diagnostic assessment to see whether there's a stiff shoulder, whether it's an instability or unstable shoulder problem, whether it's a rotator cuff or subacromial disorder, or whether it might be an AC joint, or a group of other things that we will often see. Part of that, I do ask more questions in the psychosocial domain. So it's during the assessment that I can ask the patient about their concerns, their beliefs, their expectations around treatment. So all of this is just a conversation and just questioning the patient about these things to build more of a picture of the kind of psychosocial profile, if you like.
Mm-hmm.
Then after the assessment and doing all of that, then I've got a picture of what I think the main problem is. Is this a diagnostic question? Is this a rehabilitation scenario where potentially we need to, we've found something in rehabilitation that hasn't been addressed, or the dosage needs to change, or something needs to change in the rehabilitation? Or is there is the priority the psychosocial or one of the psychosocial factors, and perhaps that might be the barrier to that patient progressing? So broadly, that's what I'm looking for at the end of my assessment, and then I direct them according to really what I find. If I think they need more investigations, we are a little bit limited in what we can access. We can access X-ray and ultrasound scan, but if it needs MRI or high-tech imaging, we often have to refer on to get that. If we think it's rehabilitation, often I will work with the referring physiotherapist if that's the case. And I do, in a lot of cases, in an increasing number of cases actually, the physiotherapists are either attending the session with the patient or they can join by telehealth. So they'll get a video link and they can watch the consultation, and that's a really effective way of being able to communicate your recommendations around rehabilitation to the treating physiotherapist. So it really works very, very well when that can happen. And if it's more of a psychosocial priority, or in some cases you might pick up patients who have nociplastic pain, so they're very pain sensitized. And if there are complexities around that are beyond the scope of the treating physiotherapist to manage, then we can also make recommendations about referring on to specialist pain management services. So that's pretty much my system for assessment.
So from my understanding, you do the first assessment after sending a lot of questionnaires, then you interview the patient, you go through the history from the very beginning, just in case something was missed, like you said. And then from what I understand, you do some sort of triage yourself, and then you refer the patient to the physical therapist that will do, for instance, the exercises, or the doctor that will do the imagery, or a psychotherapist, if needs be, if it's a more biopsychosocial problem, correct?
Yeah, that's correct. So we refer to what we are able to refer to, and if we don't have access rights, say for psychology or other things, then the general practitioner, the patient's doctor, is usually the central point for us making the recommendations, and then they can make the referrals if needed.
In what case do you recommend imagery for stiff or unstable shoulder? What are the symptoms?
Yeah, so there's a few imaging indications, and the obvious ones obviously are red flags, and
Yeah.
particularly anyone with a history of cancer, because we know that certain cancers do metastasize to bone. So X-ray, always a start point, particularly if there's a red flag. Trauma, so if they've had any significant trauma, we're looking to make sure there's been no fractures, dislocations, soft tissue ruptures. The other indications really then, especially in my setting, if patients are not improving, so the more time goes by where the patient is not improving with treatment, makes you more concerned, have we missed something? Or is there a condition on imaging that maybe needs a different type of treatment? So not improving over a reasonable time frame. Obviously 1 or 2 weeks, that's not the issue. But when I see patients 12 months or 2 years down the track, if they haven't had imaging and they're not improving, that is the indication for imaging. Also, patients who, if you're considering an injection, so most of the injections for patients that I see will be done under imaging guidance. mainly because there's a lack of access otherwise to injection services. And the radiologists generally prefer that the patient has already had imaging to make sure they know what they are injecting. So they're not injecting blind with no information.
Yeah.
So, so generally red flags, trauma, lack of progress, or if you're considering an injection, probably the other indication would be if it would change your management. So if among your differential diagnoses you think, and if I use subacromial pain as an example, so if the patient comes in and they have full passive range of motion, so it's not a stiff shoulder, they have perhaps some pain and weakness when you're doing your rotator cuff tests, and you think, okay, it may be a rotator cuff problem. There's been no history of any significant trauma, so you're not really concerned about a large rotator cuff tear or anything like that. But perhaps they're just not improving. You're doing your treatment, you're doing your exercises, and 6 months, 8 months, 9 months later, they're just still sore and just not making progress. So if you think about the range of conditions that you might see in the subacromial region, obviously there's the bursitis, there's tendinopathy, there's a rotator cuff tear, but we also have calcific tendinopathy. And I might be thinking with that patient, if they're in the age group, sort of 40 to 60 age group, ongoing rotator cuff pain, not improving despite treatment, I'd start to think, oh, maybe there's calcium involved. Maybe that could be among my differential diagnoses. My question then is, so what? So if there is calcium, would I be doing anything differently? And we do know that injection therapy does have a role for calcium. So to me, that would be an indication to get imaging, because if we find calcium, it is going to change what I do. In other words, I will refer that patient on for injection therapy. So that's probably another good indication for imaging.
Can we talk about clinical tests?
Yes, we can.
I know it's one of your favorite subjects.
Yes, it is.
What are the
What
ones
would you
that,
like to know?
well, what are the ones that you like to use that have proven efficient in your diagnosis?
Okay, very good question. So there are very few special tests, and I'm using my fingers for inverted commas here, that have enough accuracy for us to really be sure at all about the diagnosis. So if we just look at that group of tests, the special tests, the orthopedic tests, if we look at my priorities and where I make most of my diagnostic decisions, I almost talk about my level 1 tests and my level 2 tests. They would sit very firmly in my level 2 tests. In other words, they're not the tests that I use to make the majority of my diagnostic decisions. There are 1 or 2 exceptions, which I'll tell you about. But when I look at making a diagnosis, I look very much at our basic physical examination tests first. So our basic passive range of motion tests, active range of motion tests, and resisted tests. And some of you may have seen, if anyone's done any of my online courses, that I work through a systematic order of trying to identify or eliminate, firstly, a stiff shoulder. So that is our passive range of motion tests. Nothing special about those. They're just the good old-fashioned, boring passive range of motion tests, but they give you a lot of information. So if the patient has a loss of external rotation and also a loss of other passive movements, in other words, a global loss of passive range of motion, we know we're dealing with a stiff shoulder, either frozen shoulder or another joint pathology, potentially osteoarthritis, avascular necrosis, one of those conditions. So that's just passive range of motion tests. No special tests in sight yet. The next thing is really the patient history. Do they describe any history of instability? And there is one test here which can be helpful, and that is the anterior apprehension and anterior apprehension relocation test. Now that has high specificity for a structural instability lesion. So that is a labral tear, a a glenoid fracture or a capsular ligamentous tear following dislocation, but only when apprehension is used as the positive test criteria. So you can also use pain as the test criteria for that test, but the apprehension and reproduction of the apprehension symptom is more specific for those instability lesions. Then I would look at the rotator cuff, and part of that diagnosis is first having excluded the other two. So in other words, part of my rotator cuff or subacromial pain diagnosis is the fact that they have full passive range of motion. In other words, it's not a stiff shoulder. Then the next set of tests I would look at there would be my resisted tests, my resisted abduction, resisted external rotation, and resisted internal rotation. And if I'm seeing pain and weakness reproduced with those tests, I'm thinking it's more of a subacromial rotator cuff condition. This is where the special tests for impingement, if you like, or rotator cuff pain, they're very, very popular, still widely taught, I believe, but they're actually not specific for any particular rotator cuff pathology. So you could have a positive Hawkins-Kennedy test, and that stresses more than just the rotator cuff. That will also stress the AC joint, the glenoid labrum. So it's not specific to rotator cuff pain. One that again, it's a level 2 test for me, but I will use the empty can test occasionally because pain and weakness with that one can be specific for a rotator cuff disorder. The NEAR test is similar, so not really specific for a particular rotator cuff disorder. So far we've got our passive range of motion, we've got patient report of instability, maybe an apprehension test with that. We've got pain and variable weakness with those rotator cuff tests, possibly an empty can as a level 2 test for that one. And finally the AC joint, and that is, again, there's a lot of tests, special tests for the AC joint. Again, part of my diagnostic criteria for the AC joint is firstly that I have excluded a stiff shoulder. They've got full passive range of motion. They don't have, but it's not the feature is not painful weakness with the rotator cuff testing. And thereafter, then I will start to look at my other clinical features. They'll usually have pain up in that superior shoulder region. They'll often have end range pain. So although they'll have generally full passive range of motion, they may have pain at end range, particularly flexion or elevation, adduction, and internal rotation or hand behind back. So end range pain, pain on palpation, and then there are a number of other tests you could use, but they are very firmly my second priority, and they can be useful, but generally only when you use them in clusters. In other words, don't rely on one of them. You have to do a number of them, and the more of them that are positive, generally the more likely it is to be an AC joint. The ones I would use there would be the SCARF test, so adduction test, the Ryan's test, so active compression test, and the AC resisted extension test as well. All of them stress the AC joint to varying degrees, but when you put them all together, they can be helpful diagnostically. So there's no one test. If you're asking me what orthopedic tests do I use, I would use the anterior apprehension relocation test. I would use possibly the empty can test for rotator cuff or subacromial pain, and a cluster of AC joint tests if I'm really looking to get more diagnostic information. The only ones that are probably the most specific and the most helpful when it comes to looking for large rotator cuff tears, so in other words, multi-tendon tears, large tears, would be that cluster of tests that we call lag signs. So external rotation lag sign, internal rotation lag sign, lift-off test, belly press test, drop arm test, and there's a number of others. But effectively, they are putting the rotator cuff component in its inner range and asking the patient to hold. And if they can't, then
Yep.
it's a positive test. You can get some false positives with that if the patient has a neurologic deficit. So you do just have to be aware that occasionally you will get a false positive with those. But by and large, if the history fits, then they can be fairly specific for a large tear or multi-tendon tear of the rotator cuff.
Very interesting. That was a very good summary of all the tests. There's what are the most common shoulder pathologies that you encounter?
That's a good question. And again, in my setting as a physiotherapy specialist,
Mm-hmm.
I actually collected data on this and have just recently looked at it. I do see a little bit of everything.
Mm-hmm.
And in fact, almost in equal proportions, about 25% stiff shoulders, about 25% rotator cuff, 25% AC joint, and 25% other things. But what I see is there are certain age groups and certain conditions
Yeah.
within those conditions that I see more often. So if we're looking at stiff shoulder, quite often it's a frozen shoulder or arthritis. With the frozen shoulder, it's often that the patient just doesn't understand the length of time it takes for a frozen shoulder to recover. So they're often very distressed and seeking help just because they don't understand that actually this is going to take anywhere from 1 to 4 years, and it will take time, but things will eventually improve over time. That is very often what I'm doing and saying with the frozen shoulders. If I look at the unstable shoulder category, by far and away, the majority of patients I see there are more the atraumatic instabilities. So where there's been perhaps an injury to where the patient has decompensated and become unstable, but their instability lasts way beyond the period of time where they would have re-strengthened after an injury. So atraumatic instabilities in the younger patient age group, so anything from about sort of 18 to 25, very commonly see those, and some of those can be quite complex. In the rotator cuff group, generally it is one of two patient presentations. One is either the very small rotator cuff tears that are very, very irritable and painful, and that the physiotherapist is having trouble managing the pain and progressing with exercise because it's very painful. The other group that I see are the massive rotator cuff tears where the tears are inoperable and they're really functionally limited. They can't elevate their arm and they're needing specific help with the rehabilitation to regain elevation. And in the AC joint group, quite often it's a misdiagnosis. So they've been treated for neck pain or something else around the top of the shoulder for a long period of time. And very often it's either AC joint arthritis or in some cases the osteolysis that you often see with heavy weightlifters. So that's the demineralization of that lateral end of the clavicle. So those would be the most common things that I see in almost equal proportion, but affecting different age groups.
All right. Very interesting. Yeah. Very interesting. I thought the rotator cuff tears affected most of the time elderly people. Is that right?
Yes, that can be true. You very rarely, in fact, I'm not sure that I've ever seen an atraumatic or a non-traumatic rotator cuff tear in anyone under about 45 to 50 years of age. So it does seem to be that 50 plus where you tend to see the rotator cuff tears start to emerge. And we know that also from research that the prevalence of those tears increases with age as well, both the symptomatic tears and the asymptomatic tears. So it tends to be the older age group. If you're seeing a rotator cuff tear in a younger patient, quite often you'll get a rotator cuff tear if you've had a shoulder dislocation. So that's more of a traumatic tear, but very unusual to have a young person with no history of trauma who presents with a cuff tear.
Mm-hmm. Very interesting. Yeah. Can we talk about surgery and prescription of exercises? So, what is the role of physiotherapy in regards to prior to surgery, when surgery is needed, and when surgery is not needed? What are the most efficient, if I may say, exercises that can be prescribed?
Right. Oh, good question. Again, very good questions, Gabrielle. So the role of just to make sure I understand the role of physiotherapy before rotator cuff surgery in particular.
Yeah, for instance,
Yeah.
yeah. Mm-hmm.
Yeah. It's interesting, that one, because if you look at say the role of physiotherapy before other types of surgery, for example, knee joint replacement surgery and gaining quadricep strength and other things, it doesn't seem to quite work that way with rotator cuff tears, because in my experience and with the surgeons who I work with in my local area, very often the reason that they are operating is because the patient has high levels of pain and ongoing weakness as a result of their rotator cuff tear. So I often find that those patients, if you try and make them exercise more, it just increases their pain and increases their irritability and weakness. So if you're looking at prehabilitation for rotator cuff surgery, I think there may be a case potentially for prehabilitating other things if the person is generally deconditioned. But in terms of targeting the rotator cuff, I haven't found that helpful, and I find it just makes the patient sore.
Mm-hmm.
After surgery, so sorry, I can't remember the question now. What was the question around after
Oh
surgery?
yeah, the prescription of exercise after, so not necessarily after surgery, but for instance, for an unstable shoulder, for
Mm-hmm.
instance, what exercises are considered most efficient to rehabilitate the shoulder?
Yeah, okay. And that really depends on the condition, and also depends on what you are defining, how you're defining exercise.
Mm-hmm.
And this is one of the problems when we look at our research and the evidence for exercise, is the term exercise covers such a huge range of things. It covers stretching exercise, it covers isometric exercise, it's motor control, it's eccentric, it's concentric, it's heavy load, it's light load, it's scapular, it's
Mm-hmm.
cervical spine, it's thoracic spine. There's just so much that comes into that exercise group, which is why it's so difficult to find one in a randomized trial that's greater, more beneficial than another type of exercise for any given condition. But I like to keep things very, very simple. And I do find that if you're looking at those categories of patients, if we're looking at stiff shoulders, when stiffness is greater than pain, so in other words, it may have been very painful to start with, and I think there's a case for hands off if they're very irritable with exercise. But once the pain levels settle and the patient is more stiff than they are painful, stretching is the best exercise for those patients, followed maybe by strengthening. But very rarely have I ever seen a patient who remains weak and functionally limited after they regain their range of motion. So they tend to return to normal functional activities without a lot of exercise once they regain range of motion. So stretching for the non-irritable stiff shoulder. If you're looking at unstable shoulders, certainly the population I see, that is much more specific around the motor control, around the glenohumeral joint and the scapula, the rotator cuff activation, targeting specifically the rotator cuff in terms of its co-contraction function, its ability to work right through the range of motion, particularly right through internal and external rotation, and then its ability to develop force rapidly, so high velocity exercise training. So you're essentially trying to retrain the rotator cuff to maintain stability of the humeral head and react under high speed and unpredictable circumstances. So that type of exercise for the unstable shoulder. For the rotator cuff, that's an interesting one, because I know a lot of patients that I have seen with a rotator cuff disorder have had a lot of rotator cuff strengthening exercise. Most of the time, the reason they see me is because they are sore and the exercise is making them worse. So for that group of patients, if we look at the irritable rotator cuff disorders, because the massive and inoperable are a slightly different group, but if you've just got a small and irritable rotator cuff tear, then again, once the pain and irritability has settled, it's more about functional strengthening for me. If you try and target that torn, irritable rotator cuff with long lever, specific high load exercise, you're just going to make it sore. So what do those people need to be able to do? They need to be able to lift their arm up forwards in front of them, and they need to be able to externally rotate their arm. So for me, it's about the functional training in those positions in a way that is not aggravating their symptoms. It doesn't necessarily have to be pain-free, but as long as it's not making their pain any worse, then it doesn't matter what muscles they're using to do that, but if they can regain flexion and regain external rotation, that is going to be functional for them. So not targeted rotator cuff exercise, but functional exercise for that group.
With no heavy load.
No heavy load on the rotator cuff. I mean, if their arms are in close, and that's probably the other rule for those patients, if they keep their arms in close and their elbows bent, you might be able to get heavy at some point, as long as their arms are not extending a long way from their body, and as long as it's not making their symptoms any worse. Mm-hmm. And probably the final group, the AC joint group, that's scapula. Their scapula has to be working well with good force coupling, really, for those AC joint conditions. So that's probably broadly how I would approach exercise in those different patient groups.
Yeah, that's super clear and interesting. Yeah, that summarizes very well. Do you see a lot of patients who are kinesiophobic?
Yes, I do. And I would see those much more in the instability group. Mm-hmm. And to a lesser extent, probably in the irritable frozen shoulders and the irritable rotator cuff tears. And in the pain group, it's understandable, especially if they don't understand their pain. If no one's really explained to them that, or maybe they haven't had imaging, so they don't know what's going on. But as soon as they know that, look, everything in your shoulder looks fine, there's nothing serious except for this tiny little rotator cuff tear, and you can't make that any worse by doing your normal daily activities, especially if it's low load. Once they understand that, they often become a lot happier to move and much less kinesiophobic. So sometimes it's very linked to their understanding and beliefs and concerns about what's going on in their shoulder. With the instability group, it can be a little bit different because I've never dislocated my shoulder, but it does not look fun. Mm-hmm. And those patients are very happy to not dislocate their shoulder again. So they are trying very, very hard to avoid that happening. And that's understandable. And that's where it's a little bit more difficult in that patient group. And a lot of that comes down to even mental imagery, relaxation, and then also our skills as a physiotherapist in being able to give them confidence in their shoulder in ranges where they are happy and confident in their shoulder and are not kinesiophobic, and then gradually sort of moving them beyond that. But that can very much be a much more difficult task in that patient group, because we know that the fear inhibits rotator cuff activation. So it's managing the fear as well as managing the rotator cuff activation and strength concurrently in that patient group.
Interesting. Yeah. Okay. Fear inhibits the rotator cuff activation.
Yeah, it does.
Inhibits a lot of things, right?
It inhibits a lot of things. That's right. Yeah.
In terms of biopsychosocial, if you take a category, whether it's unstable shoulder, rotator cuff tear, AC joint, is there a population in particular that is like more difficult to treat and to in terms of the in terms of the psychosocial aspect? I hope I'm making myself clear. You know what I mean? Is there one that's particularly more kinesiophobic, or you were talking earlier about unstable shoulder. So obviously because they are afraid to dislocate their shoulder again, but is there an age group or a specific population?
Yeah, that's an interesting question. I think it depends on the nature of the psychosocial problem.
Mm-hmm.
And I do think the fear is a big problem in that instability group. For a lot of patients, I find that as I mentioned before, the cognitive aspects of the psychosocial, so that is the patient's beliefs, their understanding of their condition, their expectations around treatment and how timeframes for treatment, the expected outcome and prognosis. I do find that's a very common one. And once you have addressed all of those things and the patient understands their problem, their fears have been addressed. In other words, with the rotator cuff, if I lift my 2-year-old grandson, I'm going to tear it and I won't be able to lift my arm. Once you adjust their understanding and they understand the expectations around what the treatment will involve, how long it's going to take. I don't expect that you'll feel better tomorrow, but maybe in 2 weeks you should be starting to notice a change.
Mm-hmm.
Overall, this is going to take 9 months or up to 9 months. Once they understand all of that, I find that is the breakthrough needed to just get patients to move forward. Everyone's on the same page and they can all move forward together, all understanding the expected outcome. I find that does help quite a large number of patients. I probably find the ones that can be also very challenging are the ones who have diagnosed mental health conditions. So if we're looking at the psychological aspects of it, if they've got severe or significant depressive or anxiety conditions, that can be problematic. And that doesn't mean that we can't treat them and that we send them off to have that managed. It just means that they need a lot more time and understanding, and often just where normally we might give someone 3 or 4 exercises to do, maybe these patients just need 1 or 2 just to really focus on and work them through at a slower pace. So I think the diagnosed mental health conditions, if it really is a major barrier to rehabilitation, the best place for them is probably to put the physio on hold and go and manage that, and then come back when they're in a better place to work through the rehabilitation. And that's something that, I don't have to do that very often. I did have one lady who was in had just left a very abusive relationship, physically abusive relationship, and she had trespass orders, restraining orders. She was going through the courts for custody of her children, and she just, between all the different appointments she had and the stress, she was just not in a place to handle rehabilitation and put her efforts into the rehabilitation. So we agreed with her in the end, you need to just go away and manage your family situation first, and then when you're ready, you come back to me and we can continue with rehabilitation, because it was just adding stress to her life to try and keep layering this on top of everything else that was going on for her. So it sometimes just comes down to timing and priorities with them as well.
Mm-hmm. How many times would you see a patient before you refer them to another professional in general?
I mostly, in fact, about 63% of my patients, according to my own data, I will only see once. So I see them, make my recommendations, and then I send them back to the person who refers me. But if the question is how, under normal circumstances, how often would I see them? As long as I'm satisfied that I have at least excluded any significant pathologies that need onward referral, I would usually see patients 2 or 3 times. And if they are not changing as I would expect after 2 sessions, certainly 3 sessions, then I'd be asking a question. I'd be saying, have I missed something? Is this the wrong diagnosis? Is it the wrong treatment? Or is it the right treatment, but I'm just not applying it correctly? Okay, so those are sort of the 3 questions I'd ask myself. And it varies on what you're treating and what you expect in terms of how long you think things might take to show a change. But generally, I would say after 2 or 3 sessions, if they're not improving, you have to ask those questions and then act on them accordingly.
Yeah, interesting. Yeah. Angela, my last question is, if you were to talk to someone who wanted to become a shoulder specialist, what would your advice be for them?
My advice would be that you should get very, very good at doing the basics very, very well. And really, that is all experts do, is they do the basics extremely well. And in many cases, as I've pointed out some examples today, it's the simple things that have been missed. So get very, very good at doing the basics and seek out whatever education you can around the shoulder and getting the basics right in the shoulder. Seek out critique of your practice as well. I think, I don't know what it's like in other parts of the world, but in New Zealand, it's not very common that after you graduate as a physiotherapist, that you ever have anyone watching you practice and giving you feedback and advice. We are required to do it once per year for our board requirements, but outside of that, there's no critique, there's no feedback, and I don't think you can improve unless you're getting feedback. So you need to seek out someone who can give you the feedback you need to help you move forward. And the third thing would be, it takes time. It does not happen overnight. It took me probably once I set my sights on the shoulder, it took me probably 10 years to become a specialist in the shoulder, according to the New Zealand requirements for specialisation anyway. So do the basics very well, seek feedback, and just understand it takes time.
Great. Amazing. On that note, we will leave you. Thank you so much, Angela. That was super interesting. Thank you for your time, and I wish you a good day.
Thanks, Gabrielle. A pleasure to be here.
Vous aimez ce podcast? Vous avez apprécié cet épisode? Si oui, pourquoi pas laisser 5 petites étoiles sur votre plateforme d'écoute et cliquer sur le bouton s'abonner. N'hésitez pas aussi à laisser un avis ou bien à me faire un retour direct sur l'adresse email suivante kinegabrielle @gmail.com. Merci à toutes et tous et à la semaine prochaine sur Kinedi.